Okay, we'll start the meeting now. It's very nice to have you all here today. I can see the numbers are rapidly going up, so you're all getting into the meeting. Just to introduce myself, I'm Imelda Redmond. I'm the Chief Executive at Healthwatch England, and I'll be chairing this afternoon's seminar. We've got some really great speakers. It's a really interesting programme for today. Unfortunately, Professor Matthew Cripps is unable to make it simply because the technology wouldn't allow him in. He sends profuse apologies, and we're terribly sorry that he's not here. What Matthew has promised to do is to do a 10-minute recording of what he would have said, and so we'll make sure that's distributed to you after this seminar. But we still have Mike and Richard, and we'll be really interested in your questions and comments too, so there'll be plenty of time for that throughout the course at the end of the seminar. So don't forget, it's the usual things that we're all used to. Please use the chat function for your questions and your comments and to connect with each other. You've got your attendees list, but also you have a file list. So if we're talking about something that you think would be really relevant and you'd like to share a document that you've produced in the past or that you know of, please use the file and share those documents so that others can see them too. So as you know, today we're talking about the variations in healthcare. And I just wanted to take a minute or two to talk a bit about the role of Healthwatch. Healthwatch is an arm's length body. Our sponsorship department is the Department of Health and Social Care. Our role is to make sure that the voice of people who need and use services, whether that's health or social care services, is brought into the heart of the planning and design of services. We're organised in a funny old way. So I represent Healthwatch England, and then that we have 151 Healthwatch in every local authority area. Every local authority must commission one. They have to have one by statute. And that gives us this really great tentacles into communities that many organisations find very difficult to reach. There's a link to our website. If you want to know more about us, please do look at our website. We have a reports library on there that covers many of the issues that we'll be thinking about, but also in particular parts of the country as well. So I just wanted to do a little bit of reflection on the issue around variation. And for me, the issue around variation is complicated. It's not just about the data of who gets what and when. And as we open up our services towards the end of this pandemic, we need to make sure that not only do we have an eye to what's the variation, but also is that variation leading to inequalities. And I think that, you know, talking to people and listening to why it is for them that things aren't working really can make a difference in your planning. So I'll just give you one example. That's a piece of work we've done very recently about vaccine hesitancy amongst some older Black people. And actually what we found is they weren't hesitant about the vaccine, they were hesitant about using public transport. Less likely to have a car, more likely to be dependent on public transport, but because of the issues around of contact with COVID, they were less likely to use transport. So variation comes through a whole set of different reasons. And I think now, as we've learned through this pandemic, the inequalities angle has to be part of how we look at all this. So that's just a little bit about us. Please do get to know us and ask questions if you'd like to know any more, and I'll be very happy to answer them. Our first speaker was going to be Professor Cripps, but as you know, we can't have him here today. So we'll go straight to Mike Burrows. Now, Mike Burrows is the National Coordination Director for the Academic Health Sciences Network. And so, Mike, if I hand over to you.
Sure. My slides are just loading up. Thank you, Imelda. Okay, hopefully everybody can see those slides. Good afternoon, everybody. As Imelda said, my name's Mike Burrows and I work as the Coordination Director at the network of 15 academic health science networks. Oh, great, it works. Okay, I'll talk a little bit in a moment about academic health science networks. What I'm going to focus on today, though, in the time I've been allotted, is just to talk about the importance of data in reducing variation. For me, it's the absolute cornerstone of improvement in addressing variation. I think we're in an increasingly good position given the connected data and also the richness of data as well is important. I'm going to talk about and relate to the work academic health science networks do, the approach to service improvement, the importance of leadership, evidence, how it needs to be tailored, and some issues about resourcing as well. And then I'm going to reflect briefly where the opportunities may be for reducing variation, and I'll give you a little case study that I've been directly involved in. Okay, so the academic health science networks, there are 15 that cover the geography of England. We have a purpose statement to transform lives through innovation. We are funded by the national bodies, but primarily through NHS England. We also have a contract with the Office for Life Sciences. So part of our work is doing the horizon scanning and working with innovators and industry to identify and support innovation coming into the NHS. But the majority of the work that NHS England fund is around adoption and spread. It relates to innovation and service improvements as well. So we're not too tight on those definitions. Some of it might be device or technology related, but more often than not, it's about making sure that we consistently implement evidence base across the NHS. And I'll talk about that in a moment. So it's very much the day job of the work that we do as academic health science networks. Okay, so reducing variation through innovation and improvement. Firstly, the good news is that in the NHS, we've got an optimised, highly effective and efficient organisation. The future is already with us. The challenge, however, is that it's not universally here yet. You can go into a hospital and I'm sure you'll be able to find in most hospitals in the country a department which is operating at the very cutting edge of science and evidence base. And you can also probably walk 50 yards down the corridor from that department and walk into another department in the same hospital and probably find clinical practice that hasn't changed in a couple of decades. So as there's a cyberpunk novelist from the US called William Gibson, I've quoted his words there, the future is already here, it's just not very evenly distributed. And that's the issue of variation, isn't it? That it is a constant challenge in our healthcare services. So why are we slow to adopt? Well, I guess most of you will have probably seen a distribution curve like that in some shape or form. The typical profile, those people on the left-hand side, the people who are nice to work with, the innovators, the early adopters, that's the nice, safe territory that people very often migrate towards when they're undertaking piece of work like this. And then, the other end of the spectrum, I'm sorry about the pejorative language on this slide, laggards. There's a variety of reasons why people may not be early adopters, but I think you get the general take that there's that distribution of people who we would typically work with. And that's where the variation occurs in terms of where people may be on that spectrum. Interestingly, and I've put the green circle and the red circle there, we probably spend more of our time than we should do working at one end of the spectrum, the easy stuff, and probably not insufficient time at the other end of that curve with the areas where it's more difficult for that innovation to be taken up for whatever reason. And so we should really think about that in terms of how support organisations, and indeed the leadership in organisations focuses not just on the nice sexy stuff on the left hand side, but the more challenging work on the right hand side as well. Why is this important? Well, here's an interesting slide. Hope you can read that. It's a bit smaller now. This is an old research paper, but still as relevant today for me as when it was published a few years ago. And what this slide illustrates, it shows where the key landmark trials and studies were that provided the evidence to make significant changes in clinical practice across a sample of 8 or 9 piece of clinical work there. And then this study actually looked at the rate of adoption of that evidence base across the NHS in England. And there you go, that the figures speak for themselves, really, don't they? Research into routine clinical practice on average was 17 years. The average annual rate of adoption was 3.2%. So that's quite shocking, isn't it? So that demonstrates how just bringing in new landmark evidence can be really difficult to get that change fully adopted across the NHS. Part of the challenge we've had in academic health science networks and the work we do on behalf of NHS England is to try and get that message across to the national policymakers that just because evidence is there, just because there's new technology there, it does not mean it will be universally adopted. There are a whole series of barriers and challenges, and I'll come back to that point in a short while. So, improvement driven by data. Just carrying on the theme from that previous slide, I think this is a really interesting one, the example of streptokinase and the use of streptokinase in A&E in relation to myocardial infarction. The evidence of efficacy was produced in the late 80s, and it's one of those areas where there was variable uptake, significant clinical variation. And I remember at the time when the then national body brought in their targets, because it was perceived by clinicians there wasn't a problem. If you went and spoke to most physicians operating in the A&E environment, they would say they were following that evidence base. And yet when the data was captured, the information was produced, it was patently obvious that there was variation. And that was one of the key catalysts to actually to make that change, to actually expose the issue of variation, to create the feedback loop to organisations to highlight the variation. Very simple one, really. I mean, it's a really crude way around it, isn't it? The dreaded league table. But in this instance, it clearly did work. People didn't realise that there may have been out of sync with what was commonly adopted practice, and it did drive the level of that intervention up for the appropriate patient group in A&E departments. Classic example, really, of how data is important. So we've got connected data sets now. They are no longer the exception. Perhaps a few years ago we would have said they were, but we've got those connected data sets now, and that's great. It gives us data at scale. It gives us the ability to produce more comparative data. So we're in an environment now like the likes of which we've probably never seen over the last few years to use data far more effectively than we had previously. I've just put that caveat there. We know that there are still some real consent issues about using the data at scale across organisations, and that's a challenge to overcome. And the data's rich as well. Increasingly, data's captured at source. There's an increased use of devices and technologies, which means that it's not down to a coding team buried away in the basement somewhere. So that contemporaneous capture of data onto live systems, it is driving the quality of the data up, as well as the breadth of data which is being captured. Obviously, there's work that's got to be done there to make sure that data is captured in a structured basis to support the comparisons. And obviously, the use of data dictionaries is really important to make sure there's standardization of how things are recorded. And that final point, again, is illustrated by the streptokinase example. Really important that data is converted into information, and we create feedback loops from it, so we can actually produce useful information that can be applied when looking at how to tackle and address variation. I'm afraid this is a bit motherhood and apple pie for many of you, I know, but some very obvious points in terms of how you address issues in terms of bringing in service change and addressing variation. Leadership is really important, making sure the right culture is there in an organisation, that it's permissive, and that it is driven and focused through the lens of quality. For me personally, evidence is a sine qua non, although we've got to recognise and understand that there are different thresholds of evidence, when, particularly from the work we do when we're looking at bringing in evidence-based and new innovation. And also at that point, recognise that evidence isn't just about efficacy, but increasingly, obviously, in our services, cost effectiveness is an important priority as well. And that final point, resourcing. Systems do not improve themselves. Those previous slides, I think, have illustrated that. The evidence may be there. That doesn't mean the evidence will be adopted. We had to do a lot of work when we developed our national programmes across the Academic Health Science Network to actually get that message across to the people in NHS England that there's a lot of work that has to be done here. It's labour intensive. There are recognised methodologies, but even to make an improvement of adoption and uptake or reduction in variation of 10–20% in a year is actually very good progress. So this is hard, intensive work. It just doesn't happen. And you can't dodge that issue of the resources that need to be input. I'll just illustrate that later at that point as well. Where are the opportunities? This is just a very personal perspective. I think there's still quite a bit of low-hanging fruit out there in a few clinical topic areas. I've just listed a few there. I won't dwell on them. Functionally, I think there's some really interesting stuff coming out of diagnostics that can really help us to address variation, in particular around self-management, chronic disease management in the community. Some of you may be aware of the new policy which is emerging, the NHS at home stuff. That's really come to life in COVID. I think it's tremendously exciting. It does give the ability to measure far more effectively and actually empower patients as well in terms of how they can take care of their conditions. So I think there are some really interesting areas emerging as a consequence of COVID, which will continue on into the post-COVID world. I've just highlighted some technical areas as well there. I'm afraid somewhere in my back pocket there is still an accountancy qualification, and if we are truly to address inequality in the NHS, then we've got to look at the allocative as well as the technical efficiencies in the NHS. I put digital incentive systems there with a question mark. I think that digital is a solution, sometimes looking for a problem, but just relating that point back to data, if digital enables us to capture data and use that data as information more effectively, then it's got to be a key part of our armoury in addressing unwarranted variation in the NHS. I think incentive systems, I've talked there about streptokinase as an example. I think they have a part to play as well. Here's just an issue which is a bee in my bonnet, which relates to the quality and outcomes framework in primary care. And it relates back to Imelda's point about inequalities as well, actually. Hopefully you'll understand that chart. GPs get a financial reward for achievements across certain clinical domains, and there's a financial payment for that. And typically there's a threshold at which the payment's triggered, so they have to get so many percentages with a particular condition onto a disease register, or make sure that they are compliant with medication or a regimen. And that payment threshold was typically set, I don't know, 80, 85, 90%, etc. But when you actually think about that, the degree of challenge, were we actually rewarding primary care there for working with the left-hand side of that distribution curve I was illustrating earlier? So were we actually creating an inequality there, and a real troubling variation in terms of the people with whom it's easier to work with and make sure we get on the register or comply with clinical protocols, versus that tail there at the top end of the chart who are far more difficult to work with for whatever reason. So here's the borough's prescription for a quality and outcomes framework for the future. Maybe that's the way we should have thought about this. Okay, I know this is technically probably an insurmountable problem to put an incentive system in like this, but why don't we look at incentive systems where the real money is on the right-hand side of that chart, where the degree of challenge really exists. So to make sure that we can drive up 100% compliance, but we make sure that the big financial rewards are there to actually work with those patients who, for whatever reason, we really have challenges to get to on registers or comply with programs of treatment. Just a thought anyway on incentives. I said I'd talk about an example. I think I've got a couple of minutes left. We've been supporting NHS England develop the National Wound Care Strategy, and we've started the implementation of the first piece of this work around lower leg wound care. And I think it's a great example of variation, how to address it with all the issues I've just covered in the previous few minutes. It's a huge cost to the NHS. Overall wound care is estimated from the guest paper that was published last year about 8.3 billion. And as you can see, lower leg is a significant part of that that set of different wounds. It's a major problem. It has a huge impact on patients, resource intensive. It's a hidden condition. It's a group that can't advocate well for itself. It's a particularly horrible and unpleasant condition in terms of pain, in terms of the social consequence of it, such as smell, etc. And obviously, you know, it can be very life-threatening, and it results in any number of amputations. Data and information, for me, is at the heart of this issue. It's been a very poorly described and recorded condition because of poor data capture. And I think that's one of the reasons why it's been perhaps left behind in terms of some of the areas of service improvements. It doesn't have the profile, perhaps not quite as sexy as some of the other areas that we've seen. But if we get data, structured data captured properly, and we use that data, we believe there's a tremendous opportunity to address this problem. Methodology driven, data driven, and evidence driven. It ticks all the boxes. So we're ready to go with it. We've got our first wave of implementation sites now. We've got a model of care provision developed, and it's got flexibility around the edges. Through the heart of it will be data and information to make sure we can actually capture what's happening. Any piece of improvement work, you've got to have data so you can record where you currently stand and describe in numerical terms where you're seeking to get to. And all the way through, supported by the evidence base, which is now quite clear in terms of what optimal care should look like. We believe for venous ulcers, we can drive up the 12-month healing rates from 32%, can you believe that, 32%, to around 74%. That's there in the evidence base, and some very early pilots have more than substantiated that as being achievable, and that we can also address the recurrence rates as well. So there's a prevention angle to it as well. So what we're trying to do, in a sense, is deliver benefits through reducing healing time, but reducing that tail of people who have enduring lower leg wounds over an extended period of time, and obviously reduce reoccurrence as well. We've done the financials on it, and it's a fantastic one. It's the win-win, really, isn't it? So it's a great opportunity to improve patient outcomes, to improve patient quality of life, and it's cost effective as well. We recognise, as you can see, that there's a slight dip below the line. There will be input costs that will be required. As I say, this is labour intensive. There's a programme of implementation to be done here. But in terms of cash and non-cash releasing savings, we believe they are significant. So that's a really good example, I think, of where you can use leadership, where you can use data, where you can use evidence, and where you can use adoption and spread methodologies to deliver some really great and easy changes into the NHS in England. Okay, I think that's my last slide. So thank you very much. I think I'm going to hand back to Imelda now. Happy to take questions on that later on.
Thank you very much, Mike. I really appreciate that. Really interesting. Now, I put in the chat that Matthew had arrived, but I'm afraid Matthew arrived and got kicked out, and then arrived and then got kicked out. So he's been doing everything he possibly can to join us, but it's just not going to work today. But you will get the video of his presentation very soon anyway. So I move now to Richard Davies. Hello, Richard. Richard is Director of System Transformation at Smith & Nephew. Over to you.
Thank you. Can you see my slides there?
Yes. We're losing a little bit of it.
Are we? Can you see that?
It might be mine. Hang on. I can see it. Thank you. Okay,
great. Thanks. So I'm going to talk through some of the programs that we've been working with at Smith & Nephew, and it segues very nicely, actually, from what Mike was talking around with regards to data collection and the importance of information to be able to look at variation. Before we change something, we need to understand what's currently happening and what current processes are going on. And we've designed a program called the Wound Compass program, and once again it aligns very, very well with what the National Wound Care Strategy are trying to achieve also. And it is a 4-step program. I'm just going to talk you through some of the steps now. So the first part of the program is very much around orientate, where we essentially take the lid off a service. So we support the customer to carry out audits looking at things like patient demographics, looking at practice variation, clinical resource they have, clinical outcome measures, and product usage. This really lifts the lid off their system for us to be able to understand where they are at any point in time. We do prevalence audits. We've got digital enabling technologies to support with this process as well. And once again, Mike touched on the importance of digital with regards to data collection. And from the programs that we've been building, and we've built this program and rolled out in multiple areas now. And the digital element of data capture has been a really, really important part of the process. The next stage that we look at is mapping the new process. So we've collated the data, we've looked at the information, and we've looked at clinical information, product information, spend, resource, and taking all that information, it's time to build a plan. So we look at how we're able to support the different technologies that we have at this point in time. We have multiple different technologies with regards to products as well as digital technologies. And we look at how we can support the transformation of processes to help with more efficiencies. So looking at enabling technologies is a big part of what we're doing within Smith & Nephew right now. And that is the digital technologies, especially agreeing and setting KPIs for the projects, looking at how we're going to create the efficiencies and savings. So any good project, you should be forecasting to see where you want to get to, and this is the time where we're really doing that. And then agreeing a clear plan. So we put the stages in process, and we work together with our customers to see how we can move that plan forwards. The next part is activate, or execution, if you like. So this is how we look at the rollout process or an implementation process. And this is, we model our processes around a clear change management plan. The community environment especially doesn't lend itself very well to reducing variation. There are so many different factors that you need to take into consideration. Things like geography, things like product availability, prescription processes, lack of support and training for clinicians, lack of standardization in processes. The community area especially is a very difficult area to support with that. So we look at how we implement these programs, and the best way to do that is to really understand the nurses who are going to be carrying out the programs, and to do that we need to get them on board with the process, and that is very much following a change management plan. We look at the implementation. We build implementation plans, we build training plans. All this is in conjunction with the customer also. Multi-level stakeholder involvement. This is once again a key area. There are multiple stakeholders across any project, and they can come from a financial background, a clinical background, a user background, even a patient background. So it's really important that when we're doing these programs, we're engaging and securing the support of each stakeholder within the program. And then during the program, it's also very important that we're continually monitoring against the KPIs that we've agreed. So with any good project, you're continually monitoring to see if you're going off track anyway, to see if there's any tweaks or any new directions you should be moving in. And this is what, once again, a big part of what the Wound Compass program is. The final element of the program is evaluate. Let's quantify, let's measure impact. And once again, go back to the very beginning, the most important part of these type of programs is data collection, understanding where you are in the beginning and where you want to end. And then when we come to the end of the programs, we evaluate the whole system. So even though there's continuous evaluation throughout the program, we look at building a program report at the end. We look at key milestones achieved, monitoring the KPIs, feeding back to the main key stakeholders, and then looking at things like, can we move one step further with these type of processes? Can we look at clinical outcomes-based contracts, for instance? These are all the things that we're working on within Smith & Nephew. These are the programs we're working on. We're working across many different areas, acute and community areas. We've got several different digital technologies that we're able to support these processes with, as well as our products, of course. But we're trying to align as much as we can with organisations such as the National Wound Care Strategy, with NHS England, NHS Wales, Scotland, looking at how we can support with the reduction in variation, how we can utilise our resource and our digital enabling technologies to support with the overall goal of product reduction and variation, clinical reduction and variation, and so forth. And that's me. Thank you.
Thank you very much, Richard. We now have time for some Q&A, and there are a few in the chat room. The first one is from Varsha Dodia, and Varsha asks a sort of quite an existential question, really, which I could relate to completely, which is, in health, the unintended consequences in the way services are delivered, highlighted by access of issues for older Black people. Sometimes wrong conclusions are drawn because people do not ask people really why. So it's going back to, I suppose, a bit about why it's very much at the heart of the work that we do, really understanding from the individual's perspective. And I just wonder what part that plays in your modelling and your thinking. The question about why, why are you not engaging, or why are you? Why is it worse for you here than it is for these people over there? So that's the first one, and I'll go to Mike first, as he's had longer to draw his breath, and then to Richard, and then we have a couple of others that we'll come to.
It's a very well made point, Varsha, and it ties into Imelda's opening comments, doesn't it, about immunisation rates and the obvious consequence of not doing patient and public engagement right when you design services and get feedback into services. Sadly, there's still very many examples where services are designed to meet the needs of the clinical professionals rather than the needs of the patients. Can I just link that into another question as well? Is the opposite of variation standardization? Because I think we should recognise that there will be a degree of acceptable variation. I'm not saying when I talk about reducing variation that you eliminate it. You've got to apply intelligence in understanding what the particular set of issues are and what the barriers are and how to overcome those barriers. So you really do need to adopt a more intelligent approach and not the one size fits all, just to answer that point. But yeah, the unintended consequences one, really challenging. It demonstrates the importance of, as I say, making sure that you've got patient and public engagement as part of this. The work we do on adoption and spread, we do extensive patient and public involvement before we actually progress a piece of work. What we have done on the national programmes, we've trialled it in 1 or 2 health economies. We've iterated that to optimise it, to find out where the...
I think we might have lost Mike for a moment. Yes, Richard, shall I come to you, and hopefully, Mike, if you turn your camera off and on again, it might work.
Yeah, sure. I think it's a great point, right? I mean, standardization and variation. I think Mike also touched on earlier around, in some cases, the wound care area is probably behind with regards to things like data collection and looking at how we reduce variation in care and so forth. And I think, if you look at other areas like pharmaceuticals, for instance, even patient demographics are measured differently. They're measured on things like ASTRO-PU, STAR-PUs, whereas within wound care, these measurements are not really taken into consideration with regards to the variation, the types of patient there are. And once again, the variation within wound care is significant. Each wound and each patient is very, very different. I think when we talk about variation in care and how we can support to reduce it, we talk around clinical pathways, and we talk around pathways of care that allow for that variation, but support the clinician with regards to steering them in a certain way, depending on the patient that they're dealing with. So also with regards to some of the technology that we're working on, it can be around product variation as well. Product variation can cause a lot of clinical variation, if you like, with regards to confusion of the amount of products that are available on the market. So we look at how we can support with reducing that type of variation too. So good question.
Good question. And can I follow it up with this was for Mike, who's had to pop out. Hopefully he'll come back when his signal's better. But do you, in agreeing then a way forward, do you talk to the people who are on the receiving end? Now you say that you do. Mike was saying that he talks to patients in designing the pathway. Now, one of the things that we learn through HealthWatch is that's crucial. Absolutely crucial. But one of the things we also learn is there are other external factors that stop people complying as much as they would like to with their treatment. So it's the non-compliance bit. I wonder whether you do much investigation into that. Hello, Mike. It's lovely to have you back.
Sorry about that.
It happens. So, Richard, I don't know whether.
Yeah, once again, I think within wound care, as I mentioned before, the variation in care is so massive, and non-compliance, patient non-compliance is quite a large area of risk also with regards to variation. So once again, the digital technologies that we're working on allow for the variation, essentially, where even some treatments may not be as well received by certain patients as to others, and all that is taken into consideration, and they're redirected into an alternative pathway of care, essentially. So, but once again, it's definitely not reducing variation, is standardization, and I agree with what you're both saying in regards to it's almost impossible to completely standardize all processes.
Yes, it is, because you can't standardize people's interaction with each other, can you? That's the thing. But we have an interesting question here from Marcus Hinton, and it's to you, Mike, specifically. It says, where do you think that the opportunity is to improve mental health easily?
Perhaps the biggest opportunity there in terms of the variation is the resourcing issue, because we know there's still significant variation in terms of how the allocations that come down to local commissioning organisations are used, and mental health sometimes can suffer there. But there's a couple of areas. We've got programmes around children's mental health, undertaking some work in that space around ADHD, around eating disorders. Previously in another role, I've done a piece of work where we exposed quite significant variation around the physical health needs of people with mental health conditions, and also the corollary of that, how people with mental health conditions who end up sat in an acute bed for whatever reason get support in the hospital environment. Significant variation there. Perhaps one of the issues around many aspects of mental health, though, it comes back to some of the points I was talking earlier about structured data capture. So are we confident that we've got common agreed data dictionaries, so that we've got that the data that allows us to produce meaningful information to highlight variation? I think it's improved enormously over the last 5 to 10 years, but I suspect compared to what's happening in acute care, and their ability to capture data probably still a couple of years or so behind. So I do think there are a couple of areas, and there are some good publications on that are available out there.
Thank you. And I don't know whether, Richard, you had anything to add to that. Don't feel you have to.
Well, I think the only thing I would add is sometimes when we look at the structure within our own NHS, we could even start saying, well, variation needs to start, reducing variation needs to start a bit higher up as well, right? So, you know, the model of the ICS is coming in now, but it's being rolled out in varying stages at varying paces across the UK, right? And that obviously affects all services, including mental health. So I think you know, there's a lot of work to be done when we think about the wider variation of care.
Thank you. And then forgive me, I might be pronouncing this wrong, but Vyasa is agreeing with you both, saying standardization may be aspiration, but as the diversity is likely to persist. Now, we have a question from Stella, which is very, very specific, which is, she'd appreciate it if information could be given on the cause of wounds in general.
Okay.
So, yeah.
For lower leg, it generally tends to be a poor condition of the vascular system. So the underlying cause, a lot of it, obviously, there's patients with diabetes who have lower leg problems associated with vascular ill health, but that's slightly separately. I have to say, probably on the whole, largely better catered for than people with non-diabetic vascular conditions.
Thank you. And Richard, there's a question here for you from Mary Heffernan. And what Mary's interested in is that you, in community services, you've got very busy staff, you've got staffing challenges. How would you help with the initial audit process around data collection that you've talked about?
So there's two different ways that we do that. We do what we call a snapshot prevalence audit. And that can be paper-based or digital-based, which is we would look at to support an organisation to record every wound over a week's period and a prevalence in time, and then we would extrapolate that across their caseload to give them a clearer view of their wound care environment. That's one way we could do it. The other way we could do it is we've got a digital technology that we're utilizing now, where each nurse would have access to an application where they would upload all wounds that they treat, and it comes with camera technology, remote assessment capability, lots of other cool stuff that I'd love to get into more detail with if people want to on another call.
Can I have a comment there? Because I think that the new digital technologies that are coming into wound care are going to be a real game changer. And the key to it really is that it allows that contemporaneous data capture when the care is actually being provided, rather than community nurses having to go back to an office environment at the end of the day and input a load of manual data, which is seen as an added burden. So with the technologies that can capture data at the point of care provision, I think that will be a great step forward. Wound care, I think, is a great opportunity. I think it's going to be more challenging in other areas of community care. But if we can get a toehold in wound care, which I think represents, depending on the various estimates you look at, between 50 even up to 60% of district nurse time, and a significant chunk of some practice nurse time as well. If we can get that one resolved and get the data capture sorted there, that will be an enormous step forward.
Yeah, I agree. We're rolling out some programs with our digital technologies now in both acute and community, actually. So we're looking at some post-operative procedures around reducing infection and so forth with remote capabilities as well. So there's a few different things that we're doing with digital technologies now.
Okay, thank you. And Linus asks a question. Give me a moment because it's quite long. So first of all, he thanks you for your excellent presentations, and then says organisations and staff are more likely to engage and work towards innovation and addressing inequalities if it's clear to them what the benefits are and perhaps how they can share in the benefits. Do you have examples of benefits of sharing, particularly across organisational barriers? So an example, better care in primary care can reduce pressure in secondary care. And this is an interesting question because, of course, Healthwatch covers both health and social care. And we know the shunting that goes on between the two that actually reduces people's care. So who would like to go first?
I can have a crack at that. And what Linus has highlighted there comes back to my point earlier about allocative efficiency, that we use historic patterns of expenditure in large part to decide where we spend our money, and it's only in the very small margin that we think a bit more cerebrally about how we should spend money effectively to get the overall health gain. And for me, I'm an out-and-out primary care champion. I think there has to be that shift. It's difficult, though. You know that there are so many political imperatives to try and maintain the status quo. You know, A&E targets, elective weight targets, etc. And it's really, really difficult to address that. I'd also be challenging to primary care as well, though, in that respect, and say that, you know, for primary care, I'm not sure the current model of the kind of cottage industry of primary care it is fully fit for purpose for the future. And I say that to many primary care colleagues. I'm not shy about saying that. And so there's maybe work to be done on the primary care side to articulate how a new model of primary care can be delivered. One which focuses much more on population health rather than just on the kind of transactional care that sometimes primary care can find itself overwhelmed by. I think the integrated care systems which are coming into place now, if they live up to their potential, that's a big if, then if they've got the ability to move and shift resources and create the right financial environment for a move away from reactive care towards preventative care, that'll be a great thing. But that'll be a while in coming, I suspect.
Yes. And Richard, do you have anything to add to that?
Yeah, I think it's a great question, first of all. And I've got 3 words for it, which is value-based healthcare. And the reason I say those 3 words is the only way we'll join up payers and clinicians and acute and community is to work on value-based healthcare solutions. Okay, so everyone wins. The NHS can be quite siloed in with regards to budgeting and the acute versus the community, and even departments within acute and community themselves, right? If we're all striving towards the same goal, which is value-based healthcare, then that's going to take into consideration the benefits of all the processes put together, right? And essentially, that's the core of that is the patient. So if we're getting the best outcome we can get with the patient, everything else should fall in line and everyone should benefit from that process then. So 3 words, value-based healthcare.
Thank you. And Thomas Rose, I think, is just violently agreeing with you, to be honest. And that says it's the process that needs to be standardised, not the procedure of delivering clinical decisions to the patient. Isn't that the case? And I think you both absolutely agree with that.
Yeah. Just to illustrate that point, Imelda, that the wound care proposals that we're developing for lower leg don't prescribe a single approach. We recognise that there could be a variety of modes of delivery, so it's not a one size fits all.
Okay, and Paul Clayton asks, wouldn't a consistent approach of digital engagement for GP patients help to create a more credible data sets? In my experience, a shopping list is delivered to people wanting to access GP services online.
Yeah, I think I agree with that. I'm not quite sure the point of the question, but yeah, absolutely. Consistency is important. And that I come back to my earlier point about primary care being a bit of a cottage industry, it can be quite variable. I think greater consistency in primary care would be a real positive.
Yeah, I think I'll add to that with regards to digital technologies in the NHS. It's very fragmented. There's a lot of different systems operating in different areas, and the biggest challenge is to integrate new technologies into technologies that are already there, to not duplicate work. That's a real challenge, and essentially all digital technologies could stem from the GP service out, I suppose, if that was a question. But it's a big challenge digitizing the NHS, right? It's a big organisation with a lot of moving parts, so there are significant challenges.
Yes, and one of the things we know, it isn't an organisation, is it? It's a brand. It's many organisations.
Correct. Yeah.
So can I ask you both a question? And this is really about the last year where we've moved a lot of things online, where people have been doing more self-care. You can imagine now as well some wound care being doing, across online. So what have you learned from that? Not just from wound care, but what have you learned from that interaction that the public have had with services during this time that you think we should take forward?
Bit like the French Revolution, isn't it? In that question, was it succeed or not? I'll tell you in a couple of 100 years. It's possibly too early in some areas, and I think I know any number of pieces of work which are already taking place now, particularly in relation to the way we've adopted digital so comprehensively across so many services, to take a view on the effectiveness and the impact on patient outcomes of those changes. Some undoubtedly are going to be beneficial, simply in terms of resources freed up and the opportunity cost of time. And yet, I'm sure there are also going to be instances where we'll find that clinical consultations aren't as effective through the digital medium. I'll come back to my point earlier about the importance of evidence here, and I do think there'll in time need to be some significant systematic reviews so we can take a view on where we've adopted digital and it was good for us, and where we perhaps have adopted digital and perhaps need to take a more nuanced view in terms of some sort of form of decision tree, evidence-based, where digital may be applicable and where actually it's been where it's not been beneficial, and we need to work in different ways.
And quite likely it will be beneficial for some people and not for others as well, even in the same clinical pathway.
It has the potential to create inequality, certainly. Yeah.
I completely agree. I think from our perspective, what we found is, from my perspective, having worked within the wound care market for just over 10 years, since I've been in there, there's been a lot of talk around more shared care or more self-care, and patients could be changing dressings themselves and reducing the amount of nursing resource needed. I think the COVID sped that up, but it probably went a lot further than it would have in general. And I think in some cases has had a significant impact and a negative impact on patient outcomes and wound outcomes. In some areas, it's been a beneficial process to understand what type of patients could self-care, I suppose. But I think in some areas, we've got to think of the social factors as well, right? And the mental health factors of not actually seeing that clinician and the impact that can have on a patient, and especially if they're quite isolated and they're looking forward to that clinical visit per day, right? They may be able to change their own dressings, but the clinical interaction that they're getting with that person per day is more valuable to them than the dressing change. So there's a lot of different factors involved in moving things to self-care. I think some self-stroke shared care will happen now with technology, and it will be welcomed by some patients. But I think the community nursing teams and what they provide is certainly not going away.
No. Thank you. And Rumour Kincaid Weeks. Rumour is asking a question about the role that the voluntary sector and charities play in running services and the collection of data. And so I think what she would like to know is what would be of value to commissioners? Now, this is quite a difficult one, because services are often outsourced, but the data isn't always collected and used. So we're losing a big part of the knowledge that we would otherwise have. I just wonder whether you have any ideas on that.
It's enormously challenging in this area of service. I have to say largely because there's a dearth of evidence. If there's some really good hard evidence in this area, and there are elements of it, but it's difficult to see a comprehensive evidence base in this area, then that would really help. But to come back to the point earlier, it's really important to demonstrate value, and that's a currency that commissioners understand. I always say, it's not just about the efficacy. Cost effectiveness is going to be, as important for the people who are taking the decisions in the commissioning organisations. It's a challenging one. That I know some of the work I do locally outside of my day job with the HSN network in local health economies. Try to put those investments in. The primary care networks are primed now in terms of putting money into social prescribing, for example, and hats off to the central policymakers who've made that change. Perhaps what we need are some large-scale studies so we can actually prove the value, and that would enhance the ability to make investments in that area.
Okay, thank you. And we have a question from Claire Ewins, and I'd suggest you. She said what she's asking is, would you be interested in working with PPG over in East Herts and joining the dots on wound care? I'll leave you to go back to Claire directly, but Claire later says that should say using social prescribing as a process to help join the dots for patients through education and encouragement. And one of the notes I made while you were talking is we're not really talking about social prescribing. It doesn't feel integrated yet into ways of thinking. So you don't have to answer Claire's direct question about will you go to East Herts, but the bit about social prescribing and how that plays in.
There's reasonable evidence in the use of leg clubs, which is like a non-clinical model, and the value and benefit that they deliver. So, Claire, if you've got my email from earlier, please drop me a line and we can connect you into the national programme of work, no problem.
Okay, and I think that brings us to the end of all our questions. Am I right? Are there any questions I've missed? I don't think so. So just leaves me to say a big thank you to Mike and Richard for your contributions. I found them really interesting, and from the chat in the chat box, I can see that other people have been really engaged with this. Again, apologies that Matthew Cripps was unable to make it. You will get a video of his presentation. Unfortunately, you won't be able to ask the questions, which is a shame, but I'm sure there'll be a way connecting with him. So just to finish now, I just want to thank GovConnect for organising this seminar, and also with the support of Smith and Nephews. A big thank you to everybody for your contributions today, and I hope you have a very good evening. Thank you. Goodbye.
Thank you.
Bye.